Thanks very much. This is the last case, and it will be certainly a bit shorter than I think the previous ones that you've had, and hopefully provide some fruit for conversation later. There's no easy answers with this particular case. It may well raise more questions than it immediately answers. This case came across when I first moved to Westmead Hospital as a neurophysiology fellow with Professor Vujik. Essentially, Mr. PR is the type of patient generally you'd love to have. 73, retired businessman, well-spoken, plays the organ on weekends and the like. Unfortunately, over a number of, the last couple of years, his tremor has become quite a substantial problem. In particular, although he's been diagnosed with essential tremor, this tremor now intrudes quite substantially into even simple things, food, coffee cups, those sorts of things. He's always had postural and rest components with the tremor. The postural component remains the most prominent, and it's classically exacerbated by things like anxiety, improved with alcohol and the like. More recently, though, he's had increasing gait instability and some nocturnal falls. We know that he's had essential tremor for many years. It's the worsening that he's actually come to our clinic for. The tremors obviously affected the upper limbs prominently, but it's now more generalised, intruding into his voice. You can see a frontalis tremor occasionally, and into the trunk. And there's a sense of an internal tremor that can often be quite disturbing to him in quiet moments. He's got a family history of tremor in his father, a less severe phenotype, and his youngest son has developed some tremor also. So his clinical examination, his cranial nerve and cerebellar examination are largely unremarkable. There's some subtle intrusions into his horizontal saccades and a slight failure of his convergence eye movements. Sorry, I should just mention though that the key issue is that he has got some signs of a neuropathy, in particular with loss of vibration and proprioception towards the ankles with the loss of the ankle reflexes. There's no real weakness at this time. He's got some trouble with his tandem gait, though. To be honest, he can walk at least 10 steps without stepping either side. There's just some subtle kind of changes there, and there's relatively reduced arm swing bilaterally, but there's no asymmetry or Parkinsonian features either to the tremor or the gait. His medical history is notable for a diagnosed MGUS and IgG kappa that's there with a normal bone marrow, and over the time it's been under observation. It actually should read 2014, and it's been relatively stable in that 5 to 7 or 5 to 9 grams per litre. He's also been diagnosed with sleep apnea. That was diagnosed in 2012. It was done without video, but essentially he was prescribed some CPAP. That hasn't actually improved the overall pattern of his sleep, with a quality worsening such that progressively he's declined from 5 to 6 hours of good sleep to now up to 2.5 hours in each evening. The other key aspect there is he has abnormal sleep behaviours, waking up in the middle of the night, and will be found, there'll be changes in the home at night that no one is aware of during the evening, and inappropriately falling asleep on the toilet and the like. Asthma, which is otherwise well controlled. What I'll do here, just because it is a relatively straightforward case.
So we'll just sort of ask people what
Sure.
they think. So maybe, is there a fella? Maybe Nidhi. What do you think is going on, Nidhi? So he's a gentleman with an essential tremor, and I should mention that I'm not becoming a movement disorder specialist, but this was referred to me by Professor Victor Fung. So the tremor was getting much worse. He's ataxic, got this sleep problem. So what do you think is going on? And he's got this predominantly sensory neuropathy.
I guess my initial thoughts with the tremor and the paraprotein associated with the sensory neuropathy was that he might have a dad's phenotype of CIDP. I'm not really sure how to tie that in with the sleep disturbance, however.
Yeah, no, I wasn't sure either. I completely ignored the sleep disturbance. I had no idea what this guy was had at this time. I thought he probably had an anti-mag neuropathy with his tremor, although his walking wasn't quite right. And the other thing is CIDP. I mean, how common is tremor in CIDP? What do you think, Judy? Do you think it's a common thing or not?
I think it's common in that distal acquired demyelinating phenotype. I think you certainly sometimes see it in more typical CIDP. It depends a little bit, you know, where the slowing is. You get it. It's not as common in the more typical form.
Yeah, that's right. You can get it, but it's not. I agree. Yeah, that's right. So maybe let's move on to the nerve conduction studies.
So unfortunately, there's no waveforms, which I'll appreciate would have been ideal, but we'll go through these. The abnormalities are highlighted in bold in general. I think I've missed a couple of things, but if anyone could comment on the
Maybe can we get somebody to comment?
media
Dennis,
studies, I can
what
go
do you
through
think?
There's some demyelinating changes. Distal mode latency for the median nerve is prolonged and the velocity's probably in a demyelinating range. It's patchy because the ulnar nerve is less affected and you're getting, again, some other patchy, like it's variable, but I would say that there's enough to suggest there's some demyelinating pathology there.
We'll move on.
Were you convinced they're demyelinating range? I mean, there's a dominant hand distal motor latency in the median that's prolonged.
So that's true,
All
but
the upper modal conduction velocities are more than 40, and all the lower modal ones are more than 30, albeit just slightly more than 30. So it's a bit worrying that there's not a whole lot that is absolutely demyelinating.
sure.
It's very soft.
It's soft, I mean, but the velocity for the median nerve is not what you'd see with carpal tunnel syndrome. So.
It is quite low, and then these are the F waves. So what do you think of the F waves?
Well, they, again, would
These are
support...
markedly prolonged for our lab, certainly above 125%.
Yeah.
They're not dispersed. Not very dispersed.
Well,
They are.
they-
Not terribly, not enough. Right on the rating at 39 to 41.
Well, for our lab, 2 milliseconds is the chronal dispersion for the upper limbs and 4 for the lower limbs. I agree the lower limbs aren't, but they're markedly prolonged, and you can see there's actually reduced persistence of F waves throughout, with perhaps the exception of the right ulnar nerve.
Cool. And finally, sensory studies.
So again, the sensories are in keeping with what we sort of found. So, I mean, the way we reported this, we said this was suggestive of a demyelinating sensory motor neuropathy, but I can see how people would agree with that.
Do you have any features of piano playing where you can suggest that predominantly dorsal ganglion rather than more distal?
No.
You mean like pseudoathetosis? No.
Whereas extraocular movement's normal.
No, you don't.
Intrusion.
Anyway, yeah, I was just looking at whether the
Hmm.
extraocular movements were impaired.
Sorry, I didn't.
Were extraocular movements impaired?
So the only thing that was actually impaired was the failure of convergence, and that's relatively minor and is as far as I can consider, it's non-specific. But there wasn't a restriction of horizontal gaze or any other kinds of. Otherwise, pretty good, to be honest.
So Steve,
Actually, yeah.
I'm more convinced by the proximal slowing than the distal slowing. So do we have SPRs?
So certainly that's the those are the key.
Show us the
components for us.
SCPs.
I don't actually have the waveforms
Have you got the
with
results?
us. What I have is actually just what I've commented on, so it's not unfortunately a bit brief, but we didn't actually, we had a failure of essentially the tibial median nerve evoked responses.
So which ones?
So, in essence, both the with the tibial nerve summit sensory evoke responses, both the N20, which is the popliteal, which is the lumbosacral, we also did the popliteal, that was absent, and the cortical responses were markedly prolonged. They were out at 50 odd. And if you looked at the median nerve summit sensory evoke potentials, the Erb's point potential were absent, whilst the NP13 and the P19, the central responses were markedly prolonged and reasonably well formed. So, you know, based on those evoked potentials and some of the nerve conduction studies, I was sort of fairly convinced that this was a demyelinating neuropathy based on neurophysiological testing.
So in his particular case, as you mentioned, we're working on a demyelinating polyneuropathy. Essentially, we've gone through a range of different investigations. Essentially, the key points to point out are the anti-MAG antibodies are negative. We did end up having Kennedy's disease genetic testing, which was negative. And moving on, there was a range of antibodies which were undertaken. So this is actually a slightly old version, but anti-neuronal nuclear antibodies, so the ANA 1 and 2, together with a range of other antibodies, led to a immunofluorescence panel being undertaken, which our antibodies were negative. We couldn't find any of the typical kind of antibodies positive, but in his case, what this the indirect immunofluorescence staining suggested was that there was a surface antigen that was present, and that led to additional referral to a overseas laboratory for
Is John
further
Parrott
kind
here?
of
No?
sorry
Do we have-
for further testing, essentially, which we'll get.
Oh, he's got now. Okay.
Okay.
Judy, do you want to comment on this, or do you think it's? Yeah.
Okay.
Yeah, remarkable. So maybe we'll stop there, and maybe what do you think is going on? I mean, do you think this could be a demyelinating? Yeah. Okay.
Yeah.
Fair enough. Sorry. So maybe well, you know as well what's going on. So who can we ask? Neil, what do you think, mate? Okay. Jeez. Bilateral tremor, ataxia. Arun, what do you think?
I'm actually not quite sure.
That's fair enough.
I mean, it's a little hard to tease out because what I'm not completely sure of is this a systemic condition because he's got hypersomnolence? Does he actually have obstructive sleep apnea? Or is this a central and peripheral disorder with hypersomnolence, which is quite a different thing? And in terms of the ataxia, it appears that he's got ataxia that's disproportionate to his neuropathy. Is that fair to say?
I wouldn't necessarily entirely agree with that last comment, but certainly what you've mentioned, the distinction between the preceding, like whether it's a systemic problem or whether it's the background.
How quickly is this progressing? Right. Sure. How quickly is this progressing? Is this over a few weeks, months, or how?
So this is essentially the tremors gotten worse over the last 2 years.
Oh, okay.
Essentially, this is a man who can still, function for most things relatively independently. The sleep is one of the things that over the times I've seen in the last few months, it's become substantially worse. But before that, it was essentially referred for the worsening of the tremor.
Look, I actually don't know.
Okay.
All right.
So-
Yes.
I mean, the thing in the history is that this tremor goes right back to a very early age. And then the father there's a very early
There's no doubt he's got essential tremor,
Yeah.
but what's happened over the last 2 years is tremor's become quite severe and quite debilitating, which it never was. Now, I mean, essential tremors, I guess, can get worse, but to get acutely worse over the last 2 years, plus with the onset of ataxia and sensory symptoms, you kind of got to think that something else is contributing to this. And he was actually sent from Victor. Victor didn't think this was all.
what Victor thought, because I didn't think he had an essential tremor with some superimposed neurological...
Well, he thought he could probably have an his thoughts were, could this be an anti-mag neuropathy, worsening the tremor, and that's why he was sent to us. So we kind of stumbled across this answer. So maybe, I don't think anybody will get the answer.
So essentially, he was sent for further tests. So our chief scientist, after some liaison, essentially sent this sample or his serum sample across to a lab in Germany at Lübeck, and they did a kind of not routine, but a biochip kind of assay, which was negative for a range of surface antigens, antibodies at surface antigens. But what they did end up identifying after confirming our kind of immunofluorescence staining on their sample, that this gentleman actually had some antibodies to a novel antigen, IgLon5, which I'll go into in a sec. So why is this relevant?
So, Mekhi, just before you go, maybe we also did a nerve biopsy, and it's not, the nerve biopsy sort of threw up some interesting findings, so maybe we'll get Judy to just briefly comment.
So sorry, I didn't know Steve was presenting the case and I only got back this morning, so I didn't bring the biopsy, obviously.
Yep.
So the biopsy, yeah, I mean, I remember the biopsy. I would have brought pictures of the biopsy. So what there was in the peripheral sensory nerve was just marked axonal loss. So myelinated and unmyelinated fibres were all markedly reduced. There were lots of clusters, so it's been going on for a while. There were occasional actively degenerating fibres, so a chronic active axonal neuropathy. The teased fibres showed, some small thinly myelinated fibres consistent with that regeneration, but there was no segmental demyelination. There were no significant features on the teased fibre. There were these occasional sort of individual inflammatory cells around the subperineural and interneural vessels on the tall blue sections, and there were some little sort of not really cuffs but small collections adjacent to some of the epineural vessels on the H&E. Immunofluorescence just for ordinary immunoglobulin complement were negative, and Congo red for amyloid was negative. We haven't yet been able to stain the nerve for neurofacin, but we thought that was probably worth doing since there's a peripheral and central nervous system sort of flavour to it. But it looked like a peripheral sensory axonal neuropathy, and I think that fits with the neurophysiology where all of the striking features of demyelination were more proximal, and in the periphery all we're seeing is axonal loss with some minor inflammatory features.
Thank you, Judy. Now, Con, you showed us a case of that sort of patient sort of twitching. What do you think of tremor and demyelinating neuropathy? Do you think that the tremor is linked to the demyelinating neuropathy?
I mean, I think I do, yeah. Well, I don't know about this tremor because I haven't seen this man, but certainly tremor with demyelinating neuropathy is not infrequent, and sometimes the tremor can be quite severe. In fact, it can also on occasions have a resting component of a patient with anti-mag neuropathy that the tremor was present at rest and posture. Why you should get tremor in anti-mag neuropathy more commonly than other CIDPs is hard to explain, but there have been studies done looking at correlating velocity with tremor frequency, and there seems to be a correlation there in anti-mag patients. So I think it's got to do something with the 1A afferents and desynchronization of 1A afferents, which creates the loop which produces the tremor. So you rarely see tremor in pure axonal neuropathies. I mean, I can't remember the last diabetic neuropathy that had tremor.
I'm just wondering if the neuropathy was producing periodic movements in sleep and that was disrupting his sleep pattern, or do you think it was something more central than that?
No, it's something more central, and Mekti will describe now what
Okay, so with this particular case series, which was published last year, so a group in Barcelona, they were actually a sleep disorders group. They saw a series of patients who had that came to their clinic for abnormal kind of sleep behaviours actually, and then they defined on video polysomnography some characteristics. Amongst two or three, or actually the first patient, and then it evolved into 3 patients. And then they kind of pulled their kind of bank of serums to identify other patients who also had antibodies to the IgLon5 antigen. And what they've discovered, or they described, was a series of 8 patients, 4 of whom presented with sleep disorders, and 4 of whom presented with essentially gait instability. Now, all of them went on to have this kind of sleep behaviour disorder and abnormal sleep behaviours similar to what our patient has. And they all had sleep apneas, and unfortunately in all of these, or almost all of them, it is a progressive disorder. Pretty much all of them have passed on. One patient, there what did seem to be some improvements transiently with, I think they had some rituximab, but ultimately, despite downward titration of antibodies, the disorder progressed and it was fatal. 2 of those people actually went on to have brain biopsies. And although it's not a conventional tauopathy, there was phosphorylated tau within the brainstem. However, essentially the key point that we can really highlight is our patient, he does have some gait instability. He's got a demyelinating polyneuropathy, and we've got this IgLon5 antibody. Is there a way we can link this? It may be a bit tenuous at best, but so IgLon is a kind of superfamily of neuronal cell adhesion molecules. Now, people have conventionally thought of them as more involved in neuronal development, in kind of cell migration and the like. There is more work more recently, as some of you well know, in terms of patients who have CIDP. So we know that there was a paper last year describing patients with so IgG4 antibodies against neurophacin 155, who seem to have treatment refractory or IVIG refractory CIDP-associated tremor. So there may be well be a link, but to be frank, it's quite early, and this may be a novel presentation, or alternatively, this could be just a secondary manifestation of a primary neurodegenerative disease. In our patient, we're actually going to characterise this a bit further, and the nerve biopsy was one aspect of this. He's actually going for, or just finished today, a formal video, a sleep study essentially. And amongst the workup, although he's had an MR of the brain and spine, he hasn't had an MR with contrast of the spine, and he needs a CSF, but has declined that in the past. And we thought we would do some exciting excitability studies, but we'll leave that for the moment. The key issue is there that it is a novel presentation, but we need to characterise it a little bit further. It may well extend their phenotype, but we haven't proven that at this point. Do you have any comments or questions?
Dennis?
With that other series, did they determine what the reason for the antibody is? Do they think it's autoimmune, herniaplastic, or are you saying it's degenerative?
So we know that case series, that in some of their patients with the autopsy, it's a neurodegenerative process. But we also know that there were some kind of lines of evidence, pretty soft, but they all shared the same some of the HLA subtypes to suggest that perhaps there was some kind of common predisposition to developing this. It's unclear, though, whether this is just a kind of secondary phenomena of the primary neurodegenerative process where more kind of antigens presented and we kind of generate this antibody. What they have said, and that is accurate, is that it helps to further characterise or corroborate the clinical picture, which is a clinical and video polysomnography picture of essentially what is a quite difficult disease. It seems to be fatal, but relatively rare. In our case, we do need to characterise this further.
I mean, it's interesting. I've actually contacted the senior author on the paper. They haven't described neuropathies, but...
And all these patients had, except for one, had nerve studies, and they never had any.
So I think they've reported data here, but they've collected 13 so far. Peripheral neuropathy hasn't been described. But what got us thinking is that IgLon5 belongs to the neurophacin superfamily, and neurophacin-related CIDP can present with refractory tremor. So we need to still further characterise it, but one of the hypotheses is are the antibodies acting somewhere on the axon producing demyelination and also axonal degeneration.
What's the mechanism of the sleep disturbance and the behaviours? Is there antibodies there?
Now, what happens is that on the two biopsies or autopsy studies they did, and you can see there's a lot of sudden deaths for some reason. They never actually explained that. There's a deposition of hyperphosphorylated tau in the hypothalamus, the prehypothalamus, and down throughout the brainstem, the sleep centres. So the kind of sleep disorders they get is difficulty in sleep initiation, and they get fragmented sleep, but they also get sort of complex movements during their non-REM and REM sleep. And in addition to the brainstem sort of hyperphosphorylated inclusions, you also get a lot of degeneration in that region. So that's what they think is the mechanism. They're not sure whether this is autoimmune or whether it's neurodegenerative primarily. They're not sure whether the IgLon5 is an epiphenomena, and they argue that on the fact that only 1 out of the 8 patients responded to rituximab and survived. But there was this very strong HLA association to suggest autoimmunity.
When they get the treatment and recover from did they get better?
Only 1 person recovered.
So
all of them treated. 8 of them were treated, but only 1 out of the 8 basically showed some improvement, and they didn't recover.
the key issue is that, an important issue is that they targeted the antigen. They watched it go down. It didn't change the outcome. They all died. So, that's one way, one kind of support for the idea that this is a secondary phenomena. At the same time, our patient could be different altogether. We know that he responded to IVIG in the first place, and it was an appropriate delay consistent with this idea that the kind of CIDP is exacerbating a predisposition to an essential tremor. You know, the kind of delayed response is a bit different to perhaps what you might otherwise have expected. You know, he responded after a few months. His tremor improved, and then he developed a skin rash. That would fit in, I guess, conceptually in a physiological basis. So just some extra thoughts. No, so the essential kind of, so that's one thing that hasn't changed. Yeah. Thank you.
We'll call a halt to the evening. I'd like to thank everybody who presented cases and to Michelle for an excellent talk. Thank you everybody for hanging in there, and we'll meet again in August of this year. Thank you very much.